You can start now.
Okay. Hello there. I am Dr. Salim, one of the doctors in the clinic today. May I confirm you are Mr. John, 60 years old?
Yes, Doctor, I'm Mr. John.
Okay. How can I address you during the meeting today?
It's fine, you can call me John.
Okay. So, John, I'm here to ask some questions from you regarding your health condition. And after that, I would like to examine you. Would that be okay with you?
Okay, it's fine, Doctor.
Okay. John, can I ask you what brought you into the clinic today?
Doctor, I was feeling fatigued for the last 3 weeks, okay, and
Mhm.
sometimes dizzy as well.
Okay, I'm very sorry to hear this, and I will do my best to sort it out and guide you accordingly. So, can you tell me more about your complaints, the fatigue and dizziness in your
Yeah,
own words? Mm-hmm.
I was already almost 3 weeks back, and I was feeling short of breath while I was walking, and
Mm-hmm.
sometimes I was unable to catch my breath while doing my simple works, and sometimes feel dizzy as well.
Hmm. Okay, so is it for this is for the first time you are feeling, or you have the similar complaint in the past also?
I had similar complaints in the past as well.
Okay, so since how long you are feeling this type of complaints, tiredness and dizziness?
These are on and off for the last maybe few years, I can say.
Few years. Okay, okay. Okay. Can I ask you that is there any specific time of the day you are feeling this tiredness?
No, it's all the time.
Okay. And anything that makes it more worse? I mean, any activity or anything else?
Yeah, I feel that I'm unable to do my work and I feel short of breath while doing my simple work at home, simple daily activities.
Mm-hmm.
Yeah. So,
Okay. And anything that makes it better?
yeah, when I take some rest, it gets better.
Okay. Okay. Very sorry to hear that. Okay. Okay. So may I ask you regarding dizziness that this dizziness is after standing from sitting position?
Yes, yes.
And it is also like the same on and off, and since many years you are having this complaint.
Or you can say sometimes more, sometimes less, but it can happen to me.
Okay, okay, okay. Do you have any complaint of high body temperature along with that?
No, doctor.
Okay, and any weight changes you have?
No, I think same like before.
Okay, okay. Do you feel any lumps and bumps in your body?
No, doctor, I don't feel any lumps and bumps.
Okay, and how is your appetite?
It's fine.
Fine. Okay. Okay. Regarding the shortness of breath, you told me that it's you feel more short of breath when you work, right?
Yeah, yeah.
Hmm. Okay. And do you have any chest pain along with that?
No, doctor, no chest pain.
Okay. And do you feel any weakness in your leg while walking?
It's generalized throughout my body. It's not in my legs.
Okay. Okay. And do you have do you need to use any extra pillows at night due to this shortness of breath?
No, doctor.
Okay. And is it worse on lying flat also?
It's same. It's better while I'm sitting. It's better while I'm lying. It's better.
Mm-hmm. Okay. Okay. Do you have any joint pain?
No, no, doctor.
Any rash, spot, pigmentation on your body?
Uh, I saw some spots on my face, but it's.
Mhm.
I'll just show you. Can
Okay.
you see?
Yes. Yes. Sure.
Okay, can you see that?
Yes. Yes. I can see.
There's a few spots I have noticed just recently,
Mm-hmm.
but I don't know for how
Mm.
long they are there.
You don't know for how long. Okay. Okay. So you have noticed this recently, right?
Yeah.
Hmm. Okay. Do you have any mouth sores beside
No,
these rashes? Hmm.
no, doctor.
Okay. Any sores in your private area? Sorry to ask.
No, no, doctor. I don't have any.
Okay. Do you have any bleeding from any side of your body?
Yes, doctor. I'm having nosebleeds
Hmm.
frequently for the last maybe 10 years, but they're on and off. Sometimes I have to go to ENT doctor and they just do some packing. It's fine.
Okay.
Otherwise, it's going fine.
Okay, that must be very concerning. So apart from this nasal bleeding, do you have any bleeding from anywhere else? I mean, in your waterworks, in your bowel works?
Not in my waterworks, but in bowel works, I've noticed some black type stools, not recently, it's long ago, maybe 3, 4 months back. But otherwise, it's fine.
Okay, okay. So are you do you have any long-term medical illness apart from this complaint that I should be aware of?
Yeah, I'm hypertensive. Last maybe 20
You're
years.
hypertensive, okay.
Yeah.
And are you taking any specific medications? Can you show me your medication list?
I don't remember the names, doctor, but I'm using it.
Mm-hmm. Okay, okay. Are you taking any blood thinning medication for any cause?
No, doctor.
Okay, okay. And how about your diet? Is it regular, well-balanced diet?
Yeah, I'm thinking nice.
Okay. Anybody told you that you look paler than before?
What do you mean by?
Anybody has told you that you
Yeah, yeah,
look
yeah,
paler,
yeah, yeah, yeah.
more
Told me. They
paler
told.
than.
Yeah, they told me that you have changed complexion recently, but
Mm-hmm.
it's fine with me.
Okay, okay. And do you have any cough along with shortness of breath?
No, doctor.
Okay, okay. Any past surgeries or hospitalizations you have any history?
Yeah, I have been multiple times in hospitals before. Okay,
Mm-hmm.
but there's no definite surgery before.
Okay, okay. No definite surgery. Okay. I will ask you some personal questions if you don't mind. Do you smoke?
No, I don't smoke.
And what about alcohol?
No, doctor, I don't drink.
Okay. And do you drive?
Yes, I drive myself.
Okay, okay. I would like to advise you to stop driving and inform DVLA until we sort it out. Is that okay?
It's fine. Okay, doctor.
Okay. And do you recently travel in past few months or weeks?
No,
Okay. And okay. Mr. John, I would like to examine you. Is that okay?
it's okay.
Okay, so I will start with the vitals of the patient. I want to know the blood pressure and the pulse.
Okay, I'll just tell you. The pulse is 103. Okay, blood pressure is
Mm-hmm.
130/60, temperature
Mm-hmm.
37, and rate is almost 12 up to 14 breaths per minute. Okay,
Okay,
it looks
and is there
looks
okay.
pale.
Uh, okay, looks pale. Okay. And regarding the pulse, is it regular, irregular, and volume?
It's regular.
Regular. Okay, okay. I would like to ask one thing. Do you have any problem in adjusting to temperatures, high and low temperatures?
No, no, doctor. It's fine with me.
Okay, okay. And do you have any contact with the TB tuberculosis patient anywhere in the past? Any contact with the sick patient or TB patient?
No, no, doctor.
Okay, okay. Do you have any significant family history of similar illness or any other medical illness?
Yes, doctor. My brother also having similar problem, and he has this blood deficiencies, and he has been worked up in his hometown. But I don't know what exactly he's suffering from. But he has almost similar disease like me, I think so.
Mm-hmm. Okay, okay. So after a pulse and blood pressure, is there any postural drop in the blood pressure?
There's no postal drop.
Okay, I would like to check the anemia and jaundice in the eyes.
Okay, there is anemia. Okay, there's
Mm-hmm.
conjunctival pallor, but there is no jaundice in the eyes.
Okay. And is there any, apart from this reddish spots, is there any ulcers or any candidiasis or any patches in the mouth?
No,
Any dryness, dry coated tongue?
no, it's fine.
Okay, I want to check for the lymph nodes.
There's no lymphadenopathy.
Okay, okay. And then I want to check for the, I want to quickly auscultate the chest, and also I want to see chest expansion since he's having shortness of breath.
Chest is fine. There is normal vagal breathing, and chest expansion is also
Mhm.
fine. Okay.
Okay, okay. I also want to auscultate the heart. Is there any murmur or added sounds?
There is only flow murmur heard. Okay.
Low murmur. Okay, okay. Mr. John, at this point I want to ask: is there any history of any time there you feel loss of consciousness or any fainting history you have or any collapse?
No, doctor. I told you, I just feel dizzy while I was just moving up
Mhm.
from my bed. Otherwise, it's fine.
Okay, okay, okay. Do you have any history of head trauma?
No, doctor.
Okay, okay. I want to check abdomen for any visceromegaly,
There is no visceromegaly.
any pedal edema.
No.
Okay, okay, Mr. John. So, what are your concerns?
What's going on with me, doctor?
Yes, Mr. John, after examining you and after taking a history from you, I have certain possibilities in my mind. There are
Yes,
one
sir.
to two possibilities which I'm considering your family history also. But before that, I would like to do certain blood investigations, and also I would like to do certain imaging tests before reaching the diagnosis. And after that, I would be able to tell you in a more accurate way. Would that be all right?
Anything in your mind, doctor? Because I'm really disturbed.
Yes, because of your family history, I'm thinking in thinking a condition which may run in your family, and also because of these spots which you are having on your lips, and your bleeding history in your stools and nosebleed. I'm thinking of a condition called hereditary hemorrhagic telangiectasia. However, before labeling it for sure and before saying it for sure, I want to run some investigations and before I reach to the specific diagnosis. Is that okay with you?
Okay, doctor. Is it curable?
Um, I'm very sorry to say that since this is a condition which run in the families, it's not completely curable. However, we can treat your symptoms, and for that, I would like to refer you to team of doctors, which will include the blood doctor, the gland doctor, and physical physiotherapist and occupational therapist. So the team of doctors will be able to help you and will control your symptoms in a better way.
Okay, then you
Do you
explain.
have,
Yeah,
okay.
I, I got you what you told me, but I want to ask one more thing because I'm really nervous.
Mhm.
I'm
Mhm.
newly married, and maybe my children may have this problem as well, like me.
Yes, Mr. John, your concern is right. Since it is hereditary, I mean, it runs in the families. So your children has a 50% chance of having this condition. Are you getting me?
Okay, okay, doctor. Okay,
And okay, do you have any further concerns?
it's fine. It's fine, doctor. It's fine.
Okay.
You have 30 seconds, Dr. Zainab, if you want to add something.
Okay, okay. Okay, regarding the blood in your bowel works, you mentioned me. May I ask how much is the quantity of this blood, and is it fresh blood or dark stained?
It was black before, but uh,
Mm-hmm.
the quantity I can't tell you. We can say it was
Mm-hmm.
moderate in amount like that.
Okay, moderate in amount. Okay. And what about your nosebleed? It's also moderated amount
I
or
know.
is like a
Up.
huge amount? Okay, okay.
So it was a nice case done by Dr. Zainab. I'm really happy with your performance, and you did a great job by picking the science exactly, and then leading your diagnosis towards the exact diagnosis. Okay. So
Mhm.
so we will just take a few questions about this HH3.
Hello.
Hello, can you listen to me now?
Yes, it's better now, your voice. Yes.
So what's your differential diagnosis in this case?
Yes, my first differential is hereditary hemorrhagic telangiectasia. Fatigue secondary to this hereditary hemorrhagic telangiectasia. The second differential I would like to keep Addison's disease. However, I apart from postural drop, I didn't find anything which can point towards this diagnosis. Third would be any vasculitis, any other vasculitis. So
Okay.
these are my differentials.
Okay. So how you investigate this case? Investigate.
Yes, first I would like to do all the baseline investigations, including the CBC with the CBC to look for anemia, along with the peripheral smear, the renal function test and electrolytes, and the liver function test. Also, I want to do ESR and CRP to look for inflammatory markers. Then I want to do autoimmune and vasculitis profile, including ANA, CNCA, PNCA to rule out other vasculitis. And what else I can do? And genetic testing for HHT.
Okay.
And then investigations for the complications. I would like to do ECG, echocardiography, and also because the patient is having blood in the stool, so I would like to do the stool detail report, a stool for culture and sensitivity, and also I want to do colonoscopy with biopsy to rule out any other causes of black stools before labeling him, before reaching to the diagnosis.
Only you will go for colonoscopy for this patient because she is having or he is having black stools. Colonoscopy only. That's enough. Do you think?
Colonoscopy with the biopsy, and also because he's having nasal bleed, so for a nasal bleed, I want to do a bronchoscopy. Yes, bronchos. And yes, for this black stool, sigmoidoscopy with colonoscopy and biopsy, and maybe CT abdomen with contrast.
Okay. So how you will manage this case?
Regarding management, I want to do general management, which will include the education and counseling of the patient and explanation of the disease, and multidisciplinary team involvement, which will include the hematologist, the genetic counselor, the gastroenterologist, and also the pulmonologist. And of course, I will involve physiotherapist and occupational therapist. Regarding the specific management, I'm not sure regarding specific management, but I want to do I would like to give medications to control his nasal bleeding and this bleeding in the stools.
Okay. Okay.
Mm.
Thank you. Thank you, Doctor.
Thank you.
So overall, you did a nice case. Okay. So it was a real scenario, and I faced this scenario almost 3 weeks back.
Mm-hmm.
And this seasoned gentleman, he came with complaints of his fatigue, shortness of breath, and he's coming on and off for the last maybe 10 years. When you asked me about previous episodes, I told you I had admission before, but you didn't ask why you were admitted and what they did for you. They did upper and lower endoscopy for this patient, and they found some results for that as well. So you can have asked the patient why you were admitted at the last time, what was the reason for that, so he can tell you more. And
Okay.
he was short of breath, and you didn't ask any transfusions before. Do you have any transfusions, blood transfusions? Okay. And I
Mm-hmm.
had, he had multiple transfusions before, maybe 4 or 5 pints every time when he's coming. Okay. And
Okay.
you quantify the blood nicely in the stools, but you should have quantified in the nasal bleed as well, because these patients, the HST, mostly they bleed profusely from the nose, and that leads to massive anemia. Okay. Their
Okay.
bleeding from the nose are massive as compared to the stools. Okay.
Mm.
So you took the symptoms, and you're guided with the symptoms, with the signs as well. So overall, it was a good case, okay, by your side. So
Mhm.
secondly, I would, regarding family history, you asked this nicely, okay, because it can guide to the diagnosis. And
Mm.
regarding investigations, you mentioned about colonoscopy only, because he was having black stools. You upper G
Mm.
endoscopy.
Okay.
Gastroscopy is much more
Mm.
important for that patient, because black stools are reason for upper GI bleeding. Okay, he was having telangiectasias in the stomach, massive, two big lesions in the stomach, and there are multiple small lesions in the colon as well.
Mhm.
And your differentials were overall HST. Okay, additions you can keep, but there was no postal drop, and there was no signs of any like postal hypotension. So down the list. Other
Okay.
things, because you can see the lesion on the face, you can keep ITP as well in your differentials. Okay, you can,
Mm.
because there was a bleeding from the nose, and he was having black stools, and he was having some spots in the oral cavity as well. So you can keep ITP in your differentials. You can keep, third thing, acquired hemophilias occur in old age. Okay, acquired
Mm.
hemophilias. Okay, as compared to
Okay.
the classical hemophilia. So
Mm.
bleeding diathesis, because family
Mm.
history is positive. So you can keep 3 or 4 differentials in this way. Okay, regarding your management, a few things I would like to tell you that these patients are usually, first of all, symptomatic management, because he comes with anemia, and we have to treat the anemia first of all, and then we will treat accordingly. These
Okay.
patients does not need screening. Okay, for
Mm.
all the, for example, a patient is diagnosed with HST, does he need screening for brain lesions, for stomach lesions, for hepatic lesions? No. Only screening is needed for, only screening is needed for lesions in the pulmonary
Mm.
area only, pulmonary venous malformations only, because they can lead to brain abscesses, and they can lead to strokes. So only thing they can do screening for, only lung screening, okay, pulmonary screening, pulmonary AVM, pulmonary AV malformations. While, because the
Mm.
studies shows that if they screen for brain lesions or hepatic lesions, and they treat those lesions, the complications are more as compared to the benefit. So they go only for screening for pulmonary lesions only. Okay,
So what test will we do for screening?
screening, we have CT, we can do CT, we can do bubble contrast echocardiography, also can be used for these reasons. Okay. For stomach, we have CT with the contrast. For this patient, we did CT with contrast because he was having hepatomegaly. So, but there was no
Mm-hmm.
AV malformation in this case. Only he was having telangiectasias. Okay, I will just show you.
Mm-hmm.
First of all, you can see a slide now on the,
Yes.
okay, this is HST. This diagnostic criteria is a specific criteria for that, known as Curacao criteria. Okay, Curacao criteria. It's only 4 things you're positive for those criteria. I will just mention. So these patients have spontaneous nosebleeds. Okay. Second is
Mm.
multiple mucocutaneous telangiectasias at characteristic sites. What are those sites? At around the lips, the oral cavity, and on the fingers only. Okay, these are the characteristic sites for these telangiectasias. The third is visceral involvement. They can have GA, telangiectasias, pulmonary, cerebral, or hepatic. All can be possible. But the most important for us are pulmonary ones. Okay. So
Mm.
third, fourth criteria is first the relatives will have positive history of HST. So you can see now this name stands for HST, you know very well. The second name for this disease is Osler-Weber-Rendo syndrome. It's the same, okay? Osler-Weber-Rendo syndrome. So hereditary
Mm.
hemorrhagic telangiectasias with nosebleeds. So definite, this Curacao criteria, if they are 3 out of 4 are positive, their Curacao criteria is positive, it's definite diagnosis. If 2 out of 3, that means it's probable. If 1 of 3, it's less likely. So you can see in the nasal bleeds are 90% cases they have nasal bleeds, okay? And they can be treated by lubricants, and they can be used. Cauterization can be done inside, nasal packing can be done. But they have some new studies. I will just mention you. There is a drug known as bevacizumab that is used in massive bleeds, and they can have helpful in these conditions because it's anti-angiogenic drug that reduce the blood vessels formation because they have a very fragile vessels. Malformations are there. So these drugs are used nowadays in cases of massive bleeding. Okay. Second is mucocutaneous. 50 to 80% cases, there are lesions on the oral cavity, on the tongue, as well as on the soft palate. So laser therapy can be done if there is bleeding from those sides. Otherwise, no need for cosmetic reasons. Hepatic, only 30 to 70% cases, and they don't require treatment mostly. Okay. Only they can use embolizations, okay, for hepatic lesions. Pulmonary are most important. Hello? Okay. So pulmonary is most important. Okay.
Okay.
So you can see we need screening for these lesions only. They can ask in YOR, does these patients need screening for all the lesions? No, only for pulmonary lesions. Or in pregnancy, they need this screening test. Okay. For GIT, almost 40% cases, well, CNS, if needed, then they can do MRI and accordingly clipping and everything. I will just share a second slide with you. So these are investigations which you're doing for that CBC, because we need to know how much he's having deficiency of blood and platelets count. We can just, because if platelets are normal, ITP is ruled out most likely. Okay. If it is normal, then the hemophilia type disease out. The urine for hematuria, stool for blood, as mentioned, oximetry if saturation is less, X-ray, CT is, you can specifically go for like X-ray will not tell you anything in the chest. If you suspect a case of HST, you have to go with CT with contrast, okay, or bubble contrast echocardiography that can be done. While gene testing only required for children, okay, and they can just guide the young patients toward the management. And you can involve the genetic doctor in this case as well, as you mentioned before. Endoscopy is important because they have bleeding, okay. So I told you before, the same slide shows adult must screen for pulmonary AV malformations because they are higher risk for brain strokes as well as brain abscesses from the lungs. So they need, and females before going for pregnancy, they have to undergo screening for this condition. Okay. So contrastable CT chest and echocardiography can be done. Contrastable echocardiography. So this was the case. You picked nicely the lesions, and this patient was coming to the hospital almost for the last 10 years and getting transfusions and getting from ENT the nasal packings. These are the slides from the internet, but that's before the slides were actually from the patient. Okay, the initial slides I showed you, this is from the internet like that. So this patient was coming for the last 10 years with recurrent episodes, but everyone was doing his job. Like ENT was doing nasal packing, and the GAT doctor was doing scopes and just doing argon plasma coagulation for those lesions, and medical doctor were doing what, transfusion only. So I just examined the patient clearly. I found his lesions. I got the history. So I just connected the dots and came up with the diagnosis. So that's what medicine means. You have to connect the dots, and you nicely connected the dots as well. So it's a good case. I think you are real fast in this scenario. So if any feedback from Dr. Azhar, he will just mention a few things for you.
Very well done, Dr. Zainab. You have fulfilled all the criteria and approach of this fatigue, and your time management was awesome. You started examination on 8th and 9th minute, and you have finished your all the concerns and any other remaining questions within time. That's a wonderful, because time management is very important in clinical consultation. The main barrier, the main biggest challenge for all candidates is time management. Everyone knows everything, but time management always is challenging. So you did very well. And how to approach this fatigue actually in a real long clinical consultation? I'm going to share a slide. It's a too busy slide, but a lot of information is available on this slide. So whenever you are facing a person having complaining fatigue, you must ask a few questions. What do you mean by fatigue, first of all, and do you feel dizzy or not? Then going to the, he will give you that I'm feeling fatigue all the day, or whole my body is fatigued, I'm not feeling well. Then just ask a few more questions. Ask about eat. Eat stands for exercise. Did it get better or worse with the exercise? Which area of your body is involved, and what time you are feeling fatigue more? So if the morning, then we are thinking about the OSA, and if the evening, at the end of the evening, then myasthenia gravis, and all the day. So we have a couple of differential diagnosis, all other differential diagnosis. If fatigue is acute, then we're thinking about the few viral illnesses, flu-like illness. Other it's chronic, then it's a big, it's a vast topic. You cannot grab all the differential diagnosis within a given time. So you need to categorize all these fatigue cases, how they are coming, and you can get your differential diagnosis according to this classification. If you classify fatigue with the weight loss, weight gain, no weight changes, and fatigue with the dizziness. Your case was fatigue with the dizziness. So hypoglycemia, you can rule out by your history if it's acute, anemia, Addison disease, or any organ failure that can come to the with the dizziness, fatigue with the dizziness. If patient is coming with the weight gain, you have a case, your exam, then you need to ask all the questions, but these questions must be asked at the top. That's a Cushing syndrome, hypothyroidism, OSA, or pituitary insufficiency. If there is a no weight change, then most likely cases are, neurological neuromuscular disorders, or myasthenia gravis, sorry, multiple sclerosis. If weight loss, then we have a couple of differential diagnoses. We need to put all these at the top. Then we need to evaluate according to our differential diagnosis, like malignancy, infections, rheumatological disorder, or hepatobiliary. Hepatobiliary means PBC, PSC. So these kind of cases can come up with the fatigue, only fatigue. So on the left side, I made some short mnemonic to roll out these differential diagnosis in a quick way, in a short way, in a 2 to 3 minutes, just to screen the questions. That's a maid's love rest. So MS, myasthenia gravis malignancy, A for Addison anemia, I for infection, D for drugs, diarrhea. So systemic failure, L for Lambert-Eaton syndrome and liver diseases, O for OSA, V for vasculitis, and E for endocrine disorders, R for rheumatological. So how to proceed for the examination in a given time? So hands, arms, skin, especially rash, you need to see deltoid area, any proximal myopathy, blood pressure, postal drop, thyroid. You missed the thyroid today. I was expecting that you will ask about the swallowing movement of the thyroid. And lymph nodes, you did very well. Eye edge shift movements. If you thinking about the patient is coming with the weight gain and fatigue, then you have to do the edge shift movement for the pituitary problems. Lungs, crepitations, as in this case, abdominal, liver, spleen, any mass at CNSA. CNS examination, you are going to offer only in real exam. No need to do, because time is not sufficient all the time. So you should put this offer to the examiner, sir, I would like to complete my examination by doing the CNS examination. So this is how fatigue can be approached in PACES exam. Otherwise, your performance was wonderful. You fulfill all the criteria of this, but I was expecting that you will ask that, what do you mean by fatigue? This question must be an opening question when you are going to approach a case of fatigue. Otherwise, you did very well. Wonderful. Is there any question from anyone regarding this case?